Welcome, clinical staff and medical professionals. Today, we're diving into a rigorous technical explainer on the clinical interpretation of liver function tests, or as we all know them, LFTs. I'll be your guide for this session. We are going to completely bypass the conversational basics today. Instead, we're jumping straight into the physiological realities, the nuanced diagnostic variables, and the specific laboratory interferences that dictate accurate clinical interpretations. We've got a lot of ground to cover, so let's get right to it.
Here is our syllabus for today's session. First, introduction to hepatic panels. Second, markers of hepatocellular injury. Third, decoding cholestatic liver damage. Fourth, assessing synthetic liver function. And finally, number 5, differentials and laboratory interferences.
Section 1. Introduction to hepatic panels.
I want to kick things off by posing a rather critical clinical question. Do liver function tests actually measure liver function? Seriously, think about it. Do these common, everyday blood parameters truly reflect the hepatic functional capacity, or are they simply flagging cellular distress?
Well, the absolute crucial point here is that the term liver function test is in clinical reality a bit of a misnomer. The vast majority of this biochemical panel primarily identifies patterns of cellular injury, specifically hepatocellular versus cholestatic injury. When you see elevated enzymes in the bloodstream, that typically denotes hepatocyte destruction, or perhaps a biliary obstruction. What they absolutely do not do is measure the liver's synthetic baseline. In essence, we are detecting the wreckage of damaged cells, not assessing the functional output of healthy ones. It's an important distinction to keep in mind.
Let's take a look at the standard reference ranges for these primary biomarkers. ALT typically ranges from 4 to 36 IU/L. AST sits between 5 and 30. ALP ranges from 30 to 120, and GGT generally falls from 6 to 50. But here is the thing. You can't treat these numbers as absolute, unbreakable laws. Normal intervals will absolutely vary based on the specific laboratory methodology being used. Furthermore, physiological factors play a massive role. For instance, AST and ALT values are generally higher in normal males than in females. They also directly correlate with obesity. That means your reference range is naturally going to be higher in patients with a higher body mass index. So you always have to interpret these baseline numbers within the exact context of the specific patient sitting right in front of you.
Moving on to Section 2. Markers of hepatocellular injury.
When we talk about the aminotransferases, we're talking about our primary markers of hepatocellular injury. First up is alanine aminotransferase, or ALT. This is a cytosolic enzyme that is highly concentrated right in the liver parenchyma. Its very specific localization makes ALT a highly liver-sensitive indicator. It's a fantastic marker for that. On the other hand, we have aspartate aminotransferase, or AST. AST exists as both cytosolic and mitochondrial isoenzymes, but crucially, AST is not specific to the liver. You'll find it widely distributed in the heart muscle, skeletal muscle, the kidneys, and even the brain. Therefore, if you see an isolated elevation in AST without a corresponding rise in AST, that could very well indicate a non-hepatic pathology. We're talking things like a myocardial infarction or rhabdomyosis.
Now, to be incredibly accurate with your diagnostics, you really need to understand the strict kinetic timeline of these enzymes. Following an acute cellular injury event, AST levels in the plasma will begin to elevate precisely around the 8-hour mark. From there, they'll continue to climb, reaching their absolute peak concentration somewhere between 24 and 36 hours post-injury. Now, if that insult is singular and it fully resolves, those AST levels will drop back down to a normal baseline within about 3 to 7 days. Mapping out this strict timeline is absolutely crucial because it allows you to pinpoint the precise onset of acute hepatocellular necrosis with remarkable accuracy. Okay, let's dive into a really definitive mathematical tool, the R ratio. This formula brilliantly illustrates how we clinically differentiate hepatocellular necrosis from biliary obstruction. You calculate the R ratio by dividing the ALT value by its upper limit of normal, and then dividing that result by the alkaline phosphatase value divided by its upper limit of normal. It sounds like a lot of math, but the output is incredibly useful. If your resulting R ratio is greater than 5, you have a definitive hepatocellular pattern. That means the aminotransferases are elevated completely out of proportion to ALP. Conversely, if that R ratio is less than 2, you're looking at a cholestatic pattern where the ALP dominates. And if it falls somewhere in the middle, between 2 and 5, that indicates a mixed injury pattern.
And when we examine the aminotransferases relative to one another, the ratio of AST to ALT is highly diagnostic. Specifically, an AST to ALT ratio greater than 2 to 1 is a hallmark clinical indicator. Why? Because AST activity is remarkably high in alcoholic liver disease. So this disproportionate elevation strongly indicates advanced alcoholic liver injury or acute alcoholic hepatitis. A really helpful clinical mnemonic to remember this is that AST stands for a Scotch and tonic, since it is almost always disproportionately elevated in alcoholic hepatitis.
Section 3. Decoding cholestatic liver damage.
Let's look at alkaline phosphatase, or ALP. This is our frontline marker for cholestasis, which is biliary obstruction. However, we have to be careful. ALP is part of a whole family of zinc metalloenzymes highly concentrated in the microvilli of the bile canalulus. But critically, it is also found in bones, the intestines, and the placenta. Therefore, while it is absolutely elevated during biliary obstruction, it's also going to be elevated in bone diseases like Paget's disease, osteoblastic cancers, periods of new bone growth in children, and even the third trimester of pregnancy. Because of these varied tissue origins, if you have an isolated ALP elevation, that requires further laboratory validation before you can confidently confirm a hepatic pathology.
And this is exactly where gamma-glutamyl transpeptidase, or GGTP, steps in as the ultimate tiebreaker. GGTP is highly concentrated in the liver and the biliary tract. Its elevation perfectly parallels that of ALP in obstructive liver disease. But here is the crucial differentiator. GGTP is absolutely not increased in bone disease. So the logic is simple. If you observe a raised ALP alongside a raised GGTP, you can be highly confident in a diagnosis of cholestasis. But if the ALP is raised and the GGTP is perfectly normal, the pathology is almost certainly skeletal in origin.
Section 4. Assessing synthetic liver function. Now we are getting into true liver function. Let's walk methodically through the physiological steps of hemoglobin catabolism so we can fully understand bilirubin's role here. Step 1. When red blood cells complete their 120-day lifespan, they are destroyed, and the hemoglobin is broken down into heme and globin. Step 2. That heme component is then converted into biliverdin. Step 3. Biliverdin is reduced into unconjugated bilirubin. Now this form is entirely insoluble in water, which means it must bind to albumin for transport. Finally, step 4, the liver executes its vital synthetic function by conjugating the bilirubin. It adds a molecule to make it water-soluble so it can be safely excreted through the bile into the intestines and kidneys. If there's a failure at this fourth step, it results in hepatic jaundice.
To truly grade the functional output of the liver, we have to look at protein and coagulation factor synthesis. Albumin is the most abundant blood protein, and it's synthesized exclusively by hepatic parenchymal cells to maintain oncotic pressure. Because albumin has a fairly long 21-day half-life, low levels reflect a prolonged decrease in hepatic synthesis. It's a longer-term look. Furthermore, we look at prothrombin time, or PT. This measures the rate of conversion of prothrombin to thrombin, and it relies heavily on clotting factors 2, 5, 7, and X. Every single one of those is synthesized in the liver. So, assuming vitamin K levels are adequate, a delayed prothrombin time accurately reflects a failing hepatic synthetic system. And remember, this is entirely independent of the cellular enzyme leakage we were discussing earlier.
Section 5. Differentials and laboratory interferences. We have to recognize that modern lab analyzers utilize photometry, measuring light absorbed in the UV and visible spectrums. Therefore, the integrity of the specimen is paramount to getting correct data. For example, hemolysis disrupts colorimetric assays because free hemoglobin causes severe absorbance interference, specifically right around 415 nanometers. Then you have icterus, or high bilirubin, that exerts significant spectrophotometric interference, peaking at 460 nanometers. And finally, lipemia, which is a high lipid content in the blood. This causes broad light scattering across the entire visual spectrum, from 300 to 700 nanometers. These interferences aren't just academic, they can lead to erroneous results and ultimately inappropriate medical decisions.
Beyond pre-analytical lab errors, we must vigorously consider drug-induced liver injury, or DILI, as a vital differential diagnosis anytime we see unexplained enzyme elevations. DILI is a real issue. It has a documented incidence of 19 cases per 100,000 persons. It can be predictable or unpredictable. It can be immune-mediated or non-immune-mediated, and it is most commonly triggered by everyday pharmaceuticals. We're talking about things like amoxicillin/clavulate, NSAIDs, and statins. An elevated panel practically mandates a meticulous, rigorous review of the patient's entire pharmacotherapy.
I want to conclude this explainer with a rather provocative clinical challenge. If liver function tests can present as entirely normal in cases of severe burnt-out cirrhosis, situations where there simply aren't enough living hepatocytes left in the liver to even leak enzymes into the blood, are we treating the numbers or are we treating the patient? Biochemical data, while rigorously precise and incredibly helpful, is still merely one component of a holistic clinical evaluation. The next time you order an LFT panel, I want you to step back and ask yourself what story the cells are really telling you. Keep looking beyond the numbers. Until our next clinical briefing, thank you for your time.